Good morning. I'm Megan Clowse, and I'm a rheumatologist at Duke University who spent the last 20 years focused on pregnancy in women with rheumatic disease. And I'm so pleased to be here and see the interest in this topic. So session one is going to be stakeholder perspectives on the impact of post-approval pregnancy safety studies. We're going to focus on the impact for real physicians and real women who are making decisions on a daily basis about medications to be used during pregnancy. First, we're going to hear from Mariah Leach, who is a patient who has had to struggle with these decisions herself. She also is the founder of Mamas Facing Forward, which is both an informational website, but also really a social media platform that allows women with chronic disease to really share their stories. Next, we're hearing from Keele Wurst, who is in the industry. She is a head of safety science epidemiology at GlaxoSmithKline and the co-chair of GSK's Pregnancy Outcome Advisory Panel and has been deeply in this work for a long time. Finally, we're going to hear from two separate physicians. The first is Katherine Wisner, a perinatal psychiatrist who directs the Ashner Center for the Study and Treatment of Depression Disorders at Northwestern University Feinberg School of Medicine. And finally, Geeta, Swamy, who is a maternal fetal medicine expert, as well as an expert in infectious disease and vaccination in the setting of pregnancy. And she has led numerous vaccination trials. I'm going to remind everybody that if you have questions that come up, please put them into Slido so that we can have a lively discussion at the end. And now we're going to turn to Mariah to kick us off. Thanks.
Hi, everybody. Excuse me. I'm Mariah Leach, and as you mentioned, I am a patient. I'm here to remind us that basically everything we're talking about today impacts real people with real families and real wishes to grow families. And so I'm going to share a little bit about my own experiences with pregnancy and safety data because it changed quite dramatically across my 3 pregnancies. So my first son is 11, and I was diagnosed with rheumatoid arthritis when I was 25 years old. So one of my first concerns was, how do I start the family that I always knew I wanted to have? And so my first son was 11, and at the time I was basically told, we don't have enough data, nothing is safe that we can say for sure is safe. And so I was advised to stop taking all of my medications in order to become pregnant. So I did that, and many women with RA, or some unicorn women that I do not know, they're supposed to go into remission while pregnant, but it did not happen for me. So I struggled with untreated RA through my first pregnancy, but I managed, and unfortunately, after my first son was born, I had a really terrible postpartum flare, and I had to basically make the choice, do I continue breastfeeding him or do I go back to my RA medications? And so I had to give up breastfeeding very early, and I went back to my RA medications. Knowing that I wanted a second son, we tried to see if the data had improved by the time that I wanted to get my second pregnancy, and it hadn't improved much. So I went into my second pregnancy with the same sort of advice to stop taking all of my RA medications, which I did. Only with my second pregnancy, my RA flared so terribly that we reached a point where the doctors were telling me that the uncontrolled inflammation in my body was far riskier than the RA medications, even though we didn't know that much about the RA medications. So during that pregnancy, I ended up restarting a biologic for my RA while I was pregnant. It was a really difficult and scary decision to make because I didn't have any sort of assurances that what I was doing was safe for my baby. But I was not managing the pregnancy, and I had to get to the end of the pregnancy for to meet my baby. So I did take some medications during that pregnancy with very little information. And so my second son is now 9. And it was a completely different situation by the time I was ready to get pregnant with my third baby. By that point, the data had improved to the point that I was able to talk with my rheumatologist and with a maternal fetal medicine specialist, and they recommended a biologic that didn't cross the placenta. I started that biologic before getting pregnant with my, my third baby. I managed my whole pregnancy without a postpartum flare, or without flaring during my pregnancy, and I didn't have a postpartum flare after my third baby was born. And so with that baby, I was able to make my own choices about breastfeeding, and it was a very different experience for me as a mom to have this information and make a decision that I felt comfortable with and keep my disease under control. And so I think it's important to remember that we're here to speak about women, and this is real women, real lives. And as you mentioned, I run a website and support group called Mamas Facing Forward, and this is one of the topics that comes up over and over again, is that people want to get pregnant and they don't know what's safe, and sometimes their doctors don't know what's safe, and these women are struggling to figure out where to turn. And I would like to know where they should turn so I can tell them where to turn, because they want this data, they want information so that they can make choices that they're comfortable with for their families and for their own treatment as well.
Terrific. Thank you so much. Dr. Wurst.
Thanks, everyone. I'm Keele Wurst. I'm really excited to be here to hear about the new pregnancy framework. As Mariah just highlighted, I mean, this is such an important issue for us all to work together to really give women and clinicians information that they need to make educated decisions. So I'm here to talk about the industry perspective. From that perspective, we have a number of challenges. The first is, from our clinical trial data, we have limited pregnancy exposures. This may change in the future as we start to include pregnant women in our clinical trials, but for now it really remains a gap. When a drug is marketed, we don't know who will take this medication. So we don't know how many women will take it, how many women have childbearing potential, or how many pregnant women. We also don't know how a drug will be used in clinical practice, or if there are characteristics of people that might take that medication that could impact the design that we would use to study pregnancy. As Layla touched upon, we need such large sample sizes to study birth defects. Overall birth defects alone, let alone specific birth defects that require so much sample size because they're so rare. So historically, what we've done from an industry perspective is we have set up product-specific pregnancy registries. But as Layla touched upon, they have limitations. They're voluntary reporting. We have high losses to follow-up. And sometimes they don't even include a comparison group. And they take a long time. They go on for years and years, and sometimes not even generating meaningful data to help women make decisions. So we had one pregnancy registry that went on for 13 years, and it actually met its enrollment target, but most of them do not. We had an example once from our vaccines registry where it went on for 14 years, and we collected information from 1,400 women, which sounds like a lot, but then when we take into account loss to follow-up, we actually had only 100 pregnancies with outcomes that we could analyze. But conversely, when we looked at electronic healthcare data, we were able to look at 16,000 exposed pregnancies, which is a huge difference. And so it kind of speaks to, can we use these databases more often? We had another example of a registry where it was for asthma, and we projected enrollment based on another pregnancy registry for asthma. However, when we looked at the real-world use of our medication, the difference in the populations that use the medications was vastly different. We had an older population, less women, and so that registry really didn't recruit. In that situation, we looked at using our electronic healthcare data sources, even the large electronic healthcare data sources, and we just saw very low exposure. So what we did there is actually looked at enhancing our pharmacovigilance process, and could we get more data to actually provide women and their clinicians some information. So I'm really looking forward to hearing today and how we can incorporate all these data sources from registries, from databases, and spontaneous data to really provide meaningful information to women and their clinicians. So thanks.
Thank you. Dr. Wisner.
Good morning. I'm a psychiatrist who practices in obstetrical settings, and so pregnant individuals are the sole population that I work with. I've been doing this for nearly 4 decades. Being someone who contemplates very difficult decisions with patients as they decide about medication use in pregnancy. When I started my career, the mantra was, "You're pregnant, stop all medications." I see that really hasn't changed that much. But what happened was I was watching pregnant individuals throwing themselves against seclusion room walls. So this appreciation is developing to some extent that the diseases that justify drug treatment affect pregnancy and offspring outcomes as well, and that optimal care involves a balanced approach between the control of the disease and the risk of medications. I'd like to share some observations. First of all, prescribers and patients always have incomplete data. It is always there. There's never every outcome possibly studied. So we're always working with incomplete data. There are no zero-risk options, including pregnancy itself, which has substantial mortality, especially here in America. When I do a consultation, I owe the patient up-to-the-minute information about the disease course in pregnancy and the drug risks to control that disease. I owe information about what domains of information are available. Do we have no information? Is it a brand new drug? Do we have a few case reports, large case series, or higher level data, like large-scale epidemiologic studies that have the capacity to control for confounding variables, that is, those factors that come with the disease that's being treated that affect reproductive outcomes that we need to separate from the effects of the medication. These studies take a very long time. An example is for fluoxetine, also known as Prozac, which was introduced and marketed in 1988. It has just been in the last year that we have high-quality, large-scale data to show that neurodevelopmental outcomes in children are not affected by drug use. That's 35 years. So this is the kind of information we are dealing with. A major challenge in this area is putting the risk of adverse effects into perspective. So people are often frightened by, well, if you take this drug, there's a 5 times greater risk of a particular malformation. But if the malformation occurs in 1 in 100,000 births, you're looking at 1 in 100,000 versus 5 in 100,000. And unfortunately, tackling some of the information on the internet and presenting real factual data is an increasing challenge. I also find that patients are the true experts. They're the ones making the decision about whether, with your guidance, they are going to accept the medication or not. Is the risk associated with not prescribing greater than the risk associated with prescribing? I also find that patients are often concerned about function. So will they be able to be well enough to sustain their employment, their insurance, take care of their other children? So function is an important element of the decision making. So what are unmet needs? When drugs are approved by the FDA, they're done with drug versus placebo comparison studies where the effectiveness of the drug is known as well as the side effect profile. But as we've heard, pregnant individuals are not included. Post-marketing studies, however, tend to focus on adverse maternal and offspring effects. And the control of the illness piece is largely missing in most of the way these studies are designed. We need to collect data on the disease course during treatment. Is the drug as effective in pregnant as in non-pregnant populations? It is well known that there are pharmacokinetic changes in liver enzyme function. They're activated often in pregnancy, and concentrations of medications decline. So we need more information on dose optimization. Another problem is that more and more individuals who are pregnant have complex diseases, and multiple medications are often required to control those diseases. The literature is set up around single drug use, single drug effects. So we have to kind of put together what are the drugs and make some estimate without data, much data, about what the effects may be. So thank you for allowing me to present today, and I'm really looking forward to this conference.
Excellent.
Thanks.
Swamy.
So the benefit of going last is to not repeat, but to think about how to be additive. And so as sitting here on the panel as a physician representative or a clinical provider, you know, one of the things that strikes me is the role that providers play. Both as OBGYNs or obstetric providers, as well as other providers that might be caring for the pregnant person or individual seeking pregnancy. And one of the things that strikes me is that we really are supposed to be providing care, providing information, providing a pathway, not standing in the way. And so if we function as gatekeepers, then we're already doing a disservice to our patients. And I'll give you an example of that that's completely different from this space. But really, if we look to what has happened over the evolution for the last, gosh, I guess 20 plus years now, for when we used to require annual exams with a pap smear. And that was our gatekeeper to contraception. We would not give you a refill on your oral contraceptives or whatever it was unless you came in for that exam, because we wanted to make sure we screened you for cervical cancer. You could argue that we also shouldn't want you to become pregnant if you don't want to. So why were we using one in place of the other as a gatekeeper? And it's a similar thing that I find that there can often be discussions or maybe disagreements between, say, obstetric providers and, say, other subspecialist providers. So we might have a scenario where I know that every time I see a pregnant person who has a medical condition, I'm pretty certain that if I don't have a healthy pregnant person, it's unlikely I'm going to have a healthy fetus or healthy infant. So if my goal is to have a healthy mother and a healthy baby, it seems like we should be looking at those two together. But then if the individual who, say, is treating a person for rheumatoid arthritis or, say, for ulcerative colitis or MS or some other condition says, no, we don't have data, I can't prescribe that medication, someone is holding the gate, right? So we have to also think about who the audience is well beyond the patient, who really, as you said so eloquently, are becoming the experts right in front of our eyes. And we have to be thinking about how to work together. If we look at silver linings of COVID, I would tell you that I think it's one of the first times that we have seen incredibly in-sync collaboration in the vaccine world between American College of OBGYN, Society for Maternal Fetal Medicine, the American Academy of Pediatrics, Infectious Disease Society of America, CDC, FDA, and others. But it's sad that it took a pandemic to get us all to a place where we were having conversations and agreement. Why aren't we doing that on all of these other conditions? It takes an effort, but it's not insurmountable, to be honest. It really is about coming together and thinking about what do we know, what do we not know, what do we need to figure out. Even though it was very, very, very small numbers of data, the information that came from the inadvertent conceptions from the Pfizer and Moderna studies of the COVID vaccine was still helpful information. It might be small, but I can tell you when a patient looks at you and says, what would you do? I don't want to tell them what I would do. I want to tell them what I know and how that can help us to make a decision. So really having as much information as we can, even if it seems like small numbers, it's not powered, it's not data that we would ever say, great, we're going to go with it all the time. It is still helpful because it also helps to instill some trust in our patients and their families that we are paying attention and that we're not simply, just there as, nope, sorry, we can't help you today on that. And I can't say enough about the issues related to exposure during pregnancy as well as exposures prior to or periconception. They are very different. If we continue to focus solely on the thalidomide story or birth defects, we are missing the extensive amount of time that supersedes the sort of periconception time period. One doesn't equate with the other. Layla said, right, the exposure to organ development is up to 8 weeks, right, post conception and so forth. So why do we then always look at the number of birth defects, the adverse events as birth defects, when we're talking many times about conditions that we want to treat over the course of pregnancy? Another thing that I've heard routinely, not only about, well, you stop all medications because you're pregnant, is the other aspect is stop them at the end of the pregnancy. That also wreaks havoc in so many other ways. So rather than just say, let's stop medications, why don't we think about what the best course of action is to care for the person who's standing right in front of you, and then their overall health, which includes their pregnancy and the outcomes. So that's my moment, Megan.
Terrific. Thank you. So I hope everybody puts in questions to Slido, or I can also take questions if you raise your hand, but I'm going to kick everybody off with, I know that birth defects is something that is often sort of our leading outcome, particularly in the label and so on, but what other outcomes, both as a person who has taken medicines during pregnancy, as a physician, what other outcomes matter to you when you're deciding about what to do with medicines?
I mean, for me, I'm not even sure I knew what the possibilities were. It was just kind of a scary, do you want to expose your, you've never been pregnant before the first time you're pregnant, so you're learning about pregnancy as you go. And so I don't think I knew what the possibilities were, but they were scary because suddenly it was not just my body that I was making decisions about, it was someone else's body as well. And so that made it really challenging with limited information, to make a decision to take a medication.
Absolutely. So it's almost like the vague unknown is worse than the actual
And
known.
I think in the situations where there wasn't a lot of data, my doctors couldn't provide anything that made me feel better. And there was also issues with, my OBGYN would say, ask your rheumatologist, and my rheumatologist would say, ask your OBGYN, and I was sitting in the middle going, what? Like, how am I supposed to make this work together?
Yeah.
And so I think that's becoming more common, that doctors are working more with each other, but that is a really big hurdle that a lot of patients face, is that one doctor is telling them one thing, and another doctor is telling them another thing, and they're left in the middle to decide for themselves.
Yeah, absolutely. Absolutely. Dr. Wisner or Dr. Swamy, any other outcomes that you would add to the list?
There are two that patients often ask about. One concern is for NICU admission. What kind of condition will the baby be in when the baby's born, and is there any sort of withdrawal or discontinuation? And the second is, will my baby be able to function? Are there neurodevelopmental difficulties? Those are the top two.
Yeah, the infant outcome is so hard because, one of the most common things that occurs during pregnancy is ultrasound. And I can't tell you how reassured patients are by ultrasound, but it's not exactly accurate, right? So, and that's in the setting, regardless of any medications, right? People see their fetus and they suddenly feel better. But that doesn't really tell you anything about the function, right, of the soon-to-be born infant. So I think that's a struggle, that people really want to know that their child is going to be healthy. But the other concern, to a point that Dr. Wisner raised, is looking at the impact, if we're looking at registries in the post-approval sort of space, is also about the maternal health condition. So I think looking at the outcomes in the other way is not the occurrence of an adverse outcome, but what happens in the untreated space. So if we have worsening of renal function because someone has gone off their medications, worsening of their MS because they had a relapse in between and they have a relapsing remitting sort of course, and a number of things that I could name. But if we're not looking at the overall health, then you'd also wonder, well, what is the potential alteration to life course, life expectancy of that pregnant person? Have we done such a disservice that infant then has impacts on their long-term family? And these are real things that we know in improved surveillance of maternal morbidity and mortality are happening around us.
Absolutely. Yeah, I would agree that women have often a desire just for a healthy baby, and that's actually not as clearly defined, I think, often as we would like it to be. But I think if you have children, you sort of think, right, none of them is actually perfect, right? At least mine are not. And, so nobody's perfect, right? And so that can't be what has to be the goal, right? And our patients with chronic diseases also don't have a perfect body based on what somebody would say is the right way to be, or a healthy way to be. So they're already living in sort of this space of like, well, it's not perfect, but I still want to have a child, and I still can be a wonderful parent. And I think that helping women sort of weigh the pros and cons there is really important. Are there questions from the crowd? I don't see any questions on Slido, if I'm supposed to. Yeah.
For the clinicians, do you think pregnancy loss?
Yep.
Thank you. Do you think pregnancy loss, miscarriage, is important to your patients?
Absolutely. But again, one of the issues I think there is we don't often see a lot of individuals who have a pregnancy loss. So the exposure data is really poorly captured in those individuals. And then ones that we do see, it becomes a question of, it's that sort of retrospect view, right? Maybe that was what caused it. Maybe this is what might have happened. You know, when you talk about the numbers of conceptions that end in early loss, the numbers that are then actually linked to some genetic causal relationship, which we're finding more and more, right, as we get more sophisticated genetics, that starts to dwindle down to pretty small numbers, right? So it is a concern, but I think it's also almost a very separate category, because to know about periconception exposure versus in-pregnancy exposure are really two distinct things.
Yeah, I completely agree with that, but there's a population we've begun working with, women in the infertility clinic, who often are taking psychotropic medications and who are very concerned about that question. So I've recently begun to look more carefully at the data, but that's because they're a group who is actively trying to get pregnant and wanting to understand exposures, but it's a small group.
I think the other thing that comes into play there, at least in the United States, is that we have such a high number of unplanned or mistimed conceptions that we would be in, I think, an even better place if we could be improving, you know, having the best maternal health possible going into conception, because I think that's adding to the story as well, that a lot of times, say, for example, in the space of diabetes, you know, we often see, we say diabetes is associated with miscarriage, very common, except that when you look at it, it really is A1C dependent, meaning that you can still have individuals with diabetes that's well controlled that have a miscarriage, but you could have someone without diabetes that have miscarriage. You look at individuals with high A1Cs, you know, that's where you see higher congenital malformations, higher risk factors, and so forth. So we really still have to get at that picture as well. I'm sure in the same space of having good behavioral mental health going into a conception is very different than having someone that is uncontrolled.
Absolutely.
Yeah. Yes.
Question for...
Hang on, let's turn on the mic.
Go ahead. Thank you. Question for Dr. Wurst. Could you speak to what seems like the extraordinary variability that we see across manufacturers of medications with respect to their wish to support, whether it be pregnancy registries, other pharmacovigilance activities, because absent a post-marketing requirement, they do not have to pursue those sorts of activities. So over the last 15 years, it's been noteworthy that there seems to be extraordinary variability across your industry. Some companies are extremely motivated to identify the reproductive safety data of a molecule, and other companies, frankly, have no interest whatsoever because they don't have to. I wonder if you could speak to that.
So I can speak from, I think, a company that is actually looking at pregnancy, and we have a lot of pregnancy registries, and actually GSK was one of the first companies to have a pregnancy registry, so it's been an important thing. I think it depends on what molecules and what vaccines you have in a portfolio to, you know, if you don't have a woman taking a medication, is it that important? So, but I do think that there is a movement in this area for companies to start to work together. I mean, we have an example with the EU IMI Conception Project, where we have a number of companies that have come together to assess how do we study pregnancy better. You know, how do we define elements that we need for pregnancy registries and population-based data sources? So I think the needle is moving in that, you know, I think there are companies that are starting to work together. We have another example with our asthma product that we were working with that we reached out to other companies to say, hey, you know, we know that working together and creating a disease-based registry will actually get better data. So I think, you know, there is variability. We acknowledge that, but I do think we are moving the field a little bit forward, and people are coming around to look at this important issue.
Oh, here.
Hi, good morning, and thank you for these very important and very challenging discussions on this topic. I wonder if I heard the comments about the importance of having any data, limited data, and I wonder if anyone could comment on maybe the challenges of that as well, because you can see that perhaps you're now having a false reassurance of no risk, or perhaps there's a risk that's just very, very, very rare, and you taking the patient away from receiving a medication. So I wonder if we have some discussions on that point.
I have that situation a fair amount. And what happens then, if there's very limited data or just a few case reports, what tends to happen then is the severity of the illness rises in priority. So if it's somebody who, and the other thing that happens is often the new meds, people who try those are people who have failed a lot of other trials. So you've got pretty significantly ill patients who are on this medicine. So what they tend to do is say, I'm willing to take that risk because I'm a sole provider for my family. If I lose my job, I cannot take care of the people I love. So that gets lifted. The other thing is, again, I'm talking about how risks are overvalued. The reality is that most babies are going to be born okay, right? I mean, there's rates of all of these things, but even in what was the malformation rate with thalidomide was about 25%, right? So it's not 100%. And I worry about really, again, overestimating risk. But, I'm, like you were saying, very respectful of the woman's right to choose and that I would support her no matter what she chooses. Then what I might do, thinking about Mariah's situation, is set a set of criteria. If X, Y, or Z happens, then we go back in with the medicine because it's too dangerous for your health.
Yeah, if I could add, I would say that early small data can be really helpful, and it can actually kind of set things back, actually. So in the rheumatology world, there was a paper that was published a long time ago now that was probably a misinterpretation of data, but it was presented as a plenary at the American College of Rheumatology meeting. Doctors still are holding those medications based on that, even though there's reams of data since then. And so it can be helpful, but it can also be harmful if there's not more stronger data kind of stepping in right behind.
Yeah, and I think to that point, Megan, it is also about what you do with the data, who can maybe confers to discuss what the data looks like, what the caveats might be. We have relied in our world on peer review, but peer review doesn't get at all the other aspects of the field, right? And so I think it is important to take small amounts of data and really think through it before it's simply put out there. But I think holding it back just at bay is not helpful, and not getting the right people to take a look at it and have a conversation about it.
Absolutely. There's a question up here.
One thing that's interesting about this discussion is that most of it begins with a question of someone who is already pregnant and says, "Oh, you're pregnant. Should I stop? Stop your medicines, or should I stop these medicines?" And it's a very closely related but different problem of someone who is trying to get pregnant. And how do you approach that? And of course, many of them will become pregnant and continue to take medications for they know they're pregnant. And so it's a continuum. We're going to put everyone who's trying to get pregnant who's on a medication in a registry. How are we going to act that? And in some ways, it's almost the same problem of saying, well, we don't know how this drug works in pregnant women, but this is how it works in non-pregnant people. Same thing. Well, we kind of know how the drug works in pregnant people, but we don't know how it works in someone who's trying to get pregnant.
Right.
We did some of this thinking about pharmacokinetic studies where we did pharmacokinetic study prior to conception for women who wanted to conceive, and then track them through pregnancy to look at what are the concentrations, how does the drug behave in non-pregnant and pregnant situations. So that kind of study is out there, but I do think it's an interesting possibility to also to optimize her health prior to conception. And that's the group of patients who are much more concerned about the rate of miscarriage.
And I think we're getting better and better about thinking through the mechanism of action that we know, understanding we don't know what we don't know. But at the same time, we are never going to have all the data we want ever. So it does become, even with mRNA vaccines, right? We had to make an expert decision based only on the laboratory science we had. We had to make a decision without the data that we would have wanted to. And instead what happened without a recommendation is we relied on healthcare workers who said, nope, I want the vaccine. I don't want to get COVID. Whether they were periconception, already pregnant, and so forth. And so I think it becomes using the knowledge that we have to the best we can and advising patients. But in the periconception or preconception space, as Katherine was saying, in the fertility space, we offer a lot of preconception counseling. And now that we've gone through COVID and done a lot of now telehealth, these are not incredibly complicated, visits to have. And we encourage all of our patients to do that if they have medical conditions or on medications.
All right, we've got one more question.
Thank you. Just to briefly circle back one more point on the perception of risk. I think it's an excellent point, Dr. Wisner. And I think it's all in the context as well. We can have a discussion of a malformation that can be 1 in 10,000, and yet on a completely separate point, be very accepting of a complication rate for a surgery of 20 or 30%. And so it's also, it is definitely the patient's decision, but it's also a point of education and context for the healthcare provider and an opportunity. So I just want to add that. Thanks.
Terrific. Well, we'll finish up on shared decision-making and the importance of that, which I think is what you're getting to, of really being able to help women interpret the risks that are put in front of them. So thank you. All right.
Healthy mom, healthy baby.
Oh, absolutely. That's what I say.